At the onset, thank you, Rajiv, for your kind words of introduction. So today what I am going to talk is on a new molecule called non-steroidal mineralocorticoid receptor antagonist. And there's a lot of data which is being published worldwide on this new molecule. We all have known spironolactone, we have known eplerenone, and we are looking at cardiorenal outcomes on a disease called DKD, diabetic kidney disease. And basically we know that DKD is nothing but CKD and type 2 diabetes. I do have a duality and conflict of interest for this talk because I have done some work on the molecule in its phase 3 trial program with Bayer. So we all know the global burden of diabetes in India. It's a huge burden, and we know that current Atlas estimates 77 million Indians. Currently probably it has crossed around 80 million, and we expect 100 million to be crossed soon. We are world number 2. The old Atlas predicted India to be the world number 1. We aim to be the diabetes care capital of the world. The only distressing fact today is, despite of all these new advances on medicines, the deaths due to diabetes from 4 million have gone to 6.5 million in the syndemic times or COVID times. So that's a very distressing fact. We talk of all these new molecules from SGLT2s to GLP-1s, but they have not dented the mortality. So that's excess deaths have been the huge discussion in the current times. But one thing is very clear cut: as far as diabetes mortality is concerned, despite of all the advances, 100 years of insulin, so on and so forth, we still are having a challenge as far as making people with diabetes live longer. We know that they have a shortened lifespan. And what is really worse is, when we look at type 2 diabetes, 1/3 of these people will develop chronic kidney disease. And despite of glucose control, blood pressure control and its treatments, at least more than 1/3 or 30% of them will develop CKD. We also know that there is a difference in natural history of people with CKD and type 2 diabetes. But one thing is clear cut, that the end game is end stage kidney disease. And our whole philosophy and wish is to prevent that end stage kidney disease. So clearly we know that CKD is nothing but high albuminuria as defined by a urinary albumin create more than 30 milligram per gram, or an impaired eGFR below 60, or both. That's really the cutting edge definition of CKD. And if you look at the standardized 10-year cumulative incidence on cardiovascular mortality by diabetes and kidney disease, you can see no type 2 diabetes, no CKD, 3.4%, diabetes alone 6.7%, CKD alone 9.9%, and you can see the amplifier of DKD, which is CKD plus type 2 diabetes, almost 19.6%. So 1 in 5 people are likely to die. You can see the risk going up from 2 times, 3 times, 6 times. And this is very, very compelling, and this is very distressing as well. When we look at the age adjusted, age, sex, race, smoking, history of CV disease, lipids, BMI, albuminuria, and when we correct all that, and when you look at risk of cardiovascular events in people with diabetes, it increases as albuminuria progresses and eGFR declines. You can clearly see on the left hand side the CV mortality going up, and the risk of CV death is increased as the UACR goes about 10 milligram per gram, and the risk of cardiovascular death is significantly increased when the eGFR falls below 75. So that's really something for us to look for. And one thing is very clear cut, that in clinical practice, CKD is grossly underdiagnosed in people with type 2 diabetes. And the recommended CKD testing is grossly underutilized at each stage. And this is data from the UK primary care or general practice database. CKD stage 1, stage 2, stage 3, stage 4, stage 5, where eGFR is 90 and above for 1, 60 and 89 for 2, 30 and 59 for 3, 15 to 29 for 4, and less than 15 for 5. And you can see that the diagnosis moves from 1%, 5%, 18%, 53%, 59%. So there's a gross underdiagnosis. What is novel and new? The whole progression of CKD is driven by three or a trio. The first trio we all know very well, and that is hemodynamics. And we know it's linked to elevated blood pressure and the intraglomerular pressure. So it's both systemic blood pressure and the intraglomerular blood pressure. That's the first part of the triad. The second is metabolic. Good glucose control leads to better or lesser or halt of progression. And the third component which has emerged in the last decade is inflammation and fibrosis. So it's fundamentally a trio of three things: hemodynamic, metabolic and inflow or fibro-inflammatory pathway. And from a renal standpoint, the big four are the tubulointerstitial damage and inflammation, the glomerulosclerosis, the expansion of the mesangium and the hypertrophy of the glomerulus. And that eventually will lead to kidney fibrosis and CKD progression. So really, if you look at it, this is how the whole graph will progress. And can we have options to limit it? From a hemodynamic standpoint, we have had ACE and ARBs, extraordinary evidence to show that simple, low-cost, generic ACE or ARBs can dent kidney disease. Simple thiazide like diuretics, dihydropyridine, calcium channel blockers can also have a hemodynamic impact. And it is presumed and postulated that SGLT2 inhibitors, which are now generic, can also work from the same pathway. So from a hemodynamic standpoint, ACE or ARBs, the thiazide like diuretics or the calcium channel blockers from the dihydropyridine pathway and SGLT2 inhibitors are there. When it comes to the metabolic issues, we have of course metformin, the standard metformin still having an impact. Beyond metformin, we have SGLT2 inhibitors, we have GLP-1 receptor agents and other antihyperglycemic agents. But a new kid of the block, which is being investigated worldwide now, is inflammation and fibrosis. Do we have treatment options which can have a primary target for inflammation and fibrosis? That's a target under investigation, and that's the scope of my talk today. So clearly, is there a residual DKD or is there a residual disease? Do we need something beyond probably a RAS blockade and beyond an SGLT2 inhibition? So despite, and I did make a mention that despite of RAS blockade, despite of SGLT2 inhibition, people with type 2 diabetes and advanced CKD, they are still at risk for CKD progression. This is data. First data set comes from the old trial, the renal trial, which is losartan versus placebo. Despite of RAS blockade, you can see the relative risk reduction, 16%. So clearly you can see a large area under the curve of residual risk. And then you can see the Credence trial, which is CANA with ACE and ARB, or the DAPA CKD, the type 2 diabetes group, which had ACE and ARB. Both of them still confer residual risk. So despite of RAS blockade, despite of SGLT2 inhibitor, still you will feel, and you see, and we see this also in practice because we have been using both RAS blockade and SGLT2 inhibitors for at least now 5 to 7 years. We still see a residual renal risk, and that's something. Can we modulate that? Do we have an agent for that? We do have that. And this is a bulky non-steroidal molecule called finerenone. It's a novel non-steroidal selective mineralocorticoid receptor antagonist. Not yet available in India. It's still undergoing its phase 3 research. It's available now in Europe and US. It's likely to come this year end. It's a very unique structure in selective potent interaction with the mineralocorticoid receptor. It regulates gene expression, and it has the finerenone specific gene expression which exhibits anti-fibrotic, anti-inflammatory effects. So we now have a new non-steroidal molecule which is an antagonist. How does it differ from the standard aldosterone blockers? We know spironolactone is flat like eplerenone. We know the potency of spironolactone is very potent. Eplerenone is a little less potent. The selectivity, however, of spironolactone is not so specific. That's why we get painful gynecomastia as a side effect often, sexual side effects, and its half-life is more than 20 hours. It does have an active metabolite, but is robust for blood pressure control. Alprazolam has more of a restricted use in heart failure space. It definitely has selectivity on mineralocorticoid receptor. It does not have the sexual or the gonadal impact which spironolactone has. It to lesser extent. Half-life is 4 to 6 hours. But finerenone is bulky, non-steroidal. So therefore, the renal electrolyte disturbances are less. It has a high selectivity. So the sexual side effects are not seen, and it is a very short half-life and does not have a metabolite. So it's only there for 2 to 3 hours. And therefore, the rates of hyperkalemia are very less because there is a simple treatment interruption which can make a difference. The DCGI though has approved finerenone for India, and it's indicated currently for CKD with type 2 diabetes patients to reduce the risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization of heart failure. Is yet to be commercially available for our population. You must have all read the very elegant papers published last year and this year on the Fidello-DKD and Figaro-DKD trials, which are looking at outcome data, because today we want whichever molecule comes in the kidney space and in the diabetes space, it should have hard outcome data. And the Fidello-DKD and the Figaro-DKD trial is such data which has been published in public domain now. And clearly you can see that this is 2 phase 3 trials with complementary renal and cardiovascular endpoints. In the Fidello-DKD trial, the composite endpoint is time to onset for kidney failure, sustained decrease in eGFR, or death due to kidney disease. And the secondary endpoints are same like Figaro-DKD, which is nothing but time to CV death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure, and the vice versa as a secondary endpoint. And the other endpoints are all-cause mortality, all-cause hospitalizations, change in UACR, and various other endpoints as exploratory endpoints. This is a study design. Typical type 2 diabetic patient with CKD treated either with ACE or ARB at maximum tolerated dose with normokalemia at screening, randomized double-blind placebo-controlled event-driven trial, and the primary endpoint and secondary endpoints being looked at. And Figaro-DKD study had similar data points. When it was seen, we clearly see that when we look at finerenone, it's probably the first molecule to have such a large investigation on CKD and type 2 diabetes program till date. You can see renal trial had 1513 patients, Irbesatran trial had 1715 patients, Credence had 4400 patients, Figaro and Fidello put together had 7000 plus 5000, almost 13,000 plus patients. DAPA CKD had 4,000 patients, EMPA kidney had 6,000 patients. And this is very robust because they looked at both kidney outcome and cardiovascular outcome, and that data is there in public domain now. Typically the trial duration is 5 years and 6 years. Typical age is around 65. Male preponderance, obese subjects, duration of diabetes 15 years, hypertensives, normal heart rate, A1C 7.7, and potassium being normal. And clearly comorbidities also are present in a reasonable proportion, including retinopathy in 46%, neuropathy in 25%, dyslipidemia around 40%, coronary artery disease in 1/3, ischemic stroke in 15%, peripheral artery disease in around 10%, and heart failure around 7.5%. And here you can see it is across spectrum, whether it is the eGFR spectrum or the urinary albumin ratio. The spectrum is wide and it is clear cut. And if you see the baseline medications, almost all medications are seen. So if you look at it, the median follow-up in Fidello was 2.6 years and Figaro 3.4 years. 98 and 99% of people were treated with ACE and ARBs, so there was a residual effect. There was a high adherence which was documented. And when we look at the data which is now available in public domain, both Fidelio-DKD and Figaro-DKD on efficacy and safety, on top of maximally tolerated RAS therapy, Finerenone significantly reduced the primary kidney outcome by 18%. So, clear cut and hazard ratio of 0.82 with a statistical p-value. And if you look at the pre-specified secondary kidney endpoints, they support the primary endpoint results, whether it is the reduction of USCR by 31% compared to the placebo, or the secondary composite endpoint of a hazard ratio of 0.76. And if you look at the cardiovascular endpoint, again a statistically significant reduction of 14%, 0.86 hazard ratio of time to CV death, non-fatal MI, non-fatal stroke or hospitalization for heart failure, 4 data points with a hazard ratio of 0.86. And if you look at the primary composite outcome from Figaro, which is cardiovascular, again a 0.87 hazard ratio, statistically significant, which is clearly seen. And in the Figaro, the Finerenone did not significantly reduce the clinically accepted decrease in the eGFR kidney outcome. In both the trials, potassium was increased, but the clinical impact was. So no deaths were reported due to hyperkalemia, but treatment had to be discontinued or hospitalizations due to hyperkalemia were low. So they were there, it is not that they were not absent, they were predominantly there. So from a safety standpoint, how safe is the drug? Well, the effect on blood pressure is modest. The A1C and body weight were similar in both the groups. There was no impact on acute kidney injury. If you look at every SGLT2 inhibitor, they can cause acute kidney injury, and we know that. And the sexual side effects like gynecomastia were rare and balanced between various groups. It was very well tolerated, and despite of a strong pharmacovigilance, there was no major impact between placebo and Finerenone group. It did marginally increase the potassium of around 0.2 millimole versus placebo, and once it was withheld, probably it was reversed. So summarizing, if you look at the Fidelo-DKD, it was stage 3, stage 4 CKD, while Figaro was stage 1, stage 2 CKD. So early disease, late disease. Fidelo-DKD, CKD progression reduced, CV mortality and morbidity reduced. So again, primary, secondary both met. While Figaro is the opposite, CV mortality, morbidity reduced, CKD production also reduced. So very well tolerated, hyperkalemia, minimal clinical impact. So ADA in its 2022 guidance, actually based on this data, made a change in the recommendation for level A. And the level A recommendation now in the ADA guideline as of this year is that in patients or people living with diabetes with chronic kidney disease who are at increased risk for cardiovascular events or chronic kidney disease progression and are unable to use SGLT2 inhibitors, a non-steroidal mineralocorticoid receptor antagonist, Finerenone, is recommended to reduce chronic kidney disease progression and cardiovascular events. So it's a level A recommendation. So clearly, because of its compelling evidence, large data set of a trial, phase 3 program yet to be exposed to Indian population except the phase 3 program, this has been there. So this is my final slide, that clearly now we have option. We know that in renal damage, there is a lot of aldosterone excess, and the mineralocorticoid receptor activation is overactivated. This contributes a lot to renal inflammation, renal fibrosis, and therefore this is the first agent to be a potential treatment option to slow CKD progression. And if you come 2 weeks from now at the ADA meeting, there is a whole symposium dedicated to this. And I was last week at San Diego for the ACE meeting. There was a full symposium dedicated to this. And if you come to the ESD, there is a full symposium dedicated to this. Finerenone is a novel non-steroidal selective mineralocorticoid receptor antagonist. It blocks the mineralocorticoid overactivation, reduces albuminuria, and is very, very different from the steroidal mineralocorticoid receptor antagonists like classical spironolactone or alprazolam. So it's a very different mechanism by which it works. It is hypothesized that it slows CKD progression, prevents CV events, directly targeting inflammation and fibrosis. And the data of the large 13,000 plus outcome trial population submitted both to US FDA and EMEA, the Fidelo DKD and Figaro DKD results indicate that whether it is early disease or late disease, it's a very effective agent. Thank you for a patient hearing.